When Derek asked me to come, or I think it was, and he and Dr. Peterson as well. By the way, Andy was a medical student under me at the University of Wisconsin, so I have some great stories about Dr. Peterson as well. But they said, you know, we want you to talk about some of your research, and I thought, oh boy, here we go. Everybody's going to fall asleep. So it's good that they put this one right after coffee, right? Because they asked me to talk about, quote unquote, the basic science of muscle and tendon injuries. Just going to kind of move through this, but try to give it some sort of clinical perspective that sets up the next several speakers. Talk a little bit about structure and function, obviously healing and repair, sort of the timetable for that. We'll spend a little bit of time talking about the satellite cell, which many of us refer to as the skeletal muscle stem cell, a little bit about the immunology of healing, and then this whole area about muscle fibrosis. So again, just talking about structure and function, right, because that is important. And this is going to be particularly important when we talk about muscle fibrosis, because as you can see, skeletal muscle has a nice harnessing effect, if you will, if you look at the epimysium, the perimysium, and the endomysium. And all of these structures, of course, can be injured and probably are injured during human injury. To make it a little bit more difficult, and I think this is something that's been overlooked when we start talking about muscle injury and repair from a clinical perspective, but as you know, muscle is very complex, has a lot of these structural proteins, and what's really interesting is these proteins, when they're damaged, if you will, during an injury, they actually heal at very different rates. And we'll talk about titin in a second, which is the one that gets a lot of attention. It turns out that under controlled settings, titin probably takes 3 or 4 months to heal. So I'll just plant that seed now when we start talking about orthobiologics, when we should be doing these kinds of things to our athletes. So I mentioned some of these proteins earlier, and again, I don't want to put us all back to sleep. Hopefully you had a good night, so we're going to kind of move through this. But titin's the one I want you to think about, because titin really is the bridge, if you will, that brings actin and myosin together. And as I said, if you look in controlled laboratory settings, titin probably takes 3 to 4 months to repair itself. Dystrophin's another big one, as you may or may not know, and that's particularly because of its fundamental breakdown, if you will, in muscular dystrophy. And we'll talk a little bit about that when we talk about stem cells as well. Now, another topic I think that's been overlooked in the literature in terms of injury and repair is muscle architecture. And as we all know, most muscles are not simple, right? In other words, they're not what we call paralleled fiber. The muscles do not come into the tendon directly, if you will. They come in at what's called a pennation angle. And there's some recent data out of the Australian literature looking at how these pennation angles actually change, if you will, with injury. I was on a PhD committee for a young chap by the name of Jack Hickey. You may have seen his name. If not, look for it, because it's going to be in the literature here in the next few years. And Jack's done some really nice work with ultrasound showing that looking at the pennation angle of the biceps femoris and how that changes with injury and repair. Now again, not to go back to being an engineer, but from my perspective, that has a huge effect on how that muscle can then generate force. Not sure what that means necessarily clinically yet, but I think we should be thinking about these things and maybe even the effects of rehabilitation and how that affects the muscle's pennation angle. Most of the basic science work was done in Finland by Jarvinen and Leito. There's a nice review article I would draw your attention to. This looks like a cartoon, but what it's actually showing is their explanation of the temporal healing pattern, again, in a very controlled environment. So you can see day 2 up through day 21. And in their hands, at least, they believe that it's those first few days that are critical to muscle repair, if you will, or successful repair, i.e. not producing muscle fibrosis. And I'll show you some data from our laboratory that supports that. So again, you're going to say, well, here he goes. He's in the laboratory creating these injuries in rabbits, and how the heck does this translate to the sideline, right? So what I always try to think about when I'm dealing with our athletes, and we've had a run recently of hamstring injuries for reasons we're not sure about yet, but if you look on the left side, that's the traditional slide that we show in histology, right? You get the myotendinous junction injury, you get fibers or inflammatory cells infiltrating that area, and that sets you up for successful repair. On the right-hand side is an MRI, of course, of a hamstring injury. And so how do you go, again, from bench to sideline? And I'll try to give you some examples, at least, of where I've tried to do that in my own practice. So I'll digress real quickly. As you know, I mentioned earlier, I'm from Canada. Does anybody know who said this? I'll buy you a beer. Gordie Howe, thank you. right? This is one of his famous quotes, and his son Mark, who's a good friend of mine, gave this as part of his eulogy, and it's something I try to live with every day. Okay, so this, if you take nothing else from this talk this morning, which again I hope sets the stage for when we move more towards the clinical side of things, and whether it's PRP or controlled rehabilitation or whatnot, is these are the phases of muscle healing. And again, this is a slide that I really should credit a good friend of mine, Johnny Howard, for. This is Johnny's sort of schematic as to how muscle repair and regeneration occur. And what I want to do is use this as an overview for the next few slides to kind of talk about the specifics of that, and maybe even to challenge us to think about some of the clinical tools we have in our toolbox, if you will, such as anti-inflammatories and corticosteroids. So I mentioned earlier the satellite cell, right? That's the skeletal muscle stem cell, and that's getting a lot of attention these days, these orthobiologics, regenerative medicine, and again, we'll talk about that in the next couple of talks. But suffice it to say, it's the satellite cell and its activation after an injury that's going to lead to successful repair. Most of the work in this area early on was done more with the muscular dystrophy literature, where dystrophin is absent. So it's a very different model than obviously a more healthy injury, for example, to a hamstring. What's interesting, and this is buried in the literature, and I'll leave you to think about this, is calcium actually may be a major player. It turns out, and we did some of these experiments, I mentioned earlier Tim Butterfield, who's now at the University of Kentucky. Tim did some experiments where he blocked calcium from infiltrating the muscle after this so-called delayed onset muscle soreness, and actually showed that the muscle recovered quicker, if you will, in terms of isometric torque. So the muscle stem cell, if you will, the satellite cell, it lies dormant. It's between the sarcolemma and the basal lamina. Interestingly, and this is another topic I've become interested in, is, we only have a fixed population of these satellite cells, right? So, for example, if you look at the effects of aging and exercise and you consume some of those satellite cells, what does that mean for your body's ability to heal, if you will? And the analogy I use is the 60-year-old who comes to my clinic with a hamstring injury. One of the things I explain to them is that they may not have as many satellite cells lying around. Or, for example, as my good colleague is going to talk about in a second here and tell you that PRP is the greatest treatment for muscle injuries, I would argue that you're consuming some of those precious stem cells that you may not want to get rid of. Another topic to, again, I apologize, we're moving quickly, but I just wanted to set the flavor for it, and that is blood flow. And this is a slide, again, from Dr. Howard's lab. I'm pleased to say that Johnny won the Kappa Delta Award last year. For those of you who don't know, that's the Career Award in Orthopedic Research. And I'm pleased to say that Johnny, it was long overdue. He probably should have won it about 20 years ago. In any event, what Dr. Howard has pointed out to us in terms of muscle healing, whether it's dystrophic muscle or healthy muscle, is it may actually come down to blood flow. And so Johnny's done some very eloquent work where he's actually controlled blood flow in terms of blood flow to the muscle and showed that has profound effects on healing. Again, where am I going with this? Well, what I'm challenging us to think about is from a clinical perspective. We heard a great talk on blood flow restriction. So my argument or my suggestion would be, how does that actually affect blood flow to a healing skeletal muscle? So I mentioned earlier the immunology, right? And again, this is not to sort of get bogged down on all of this, but what I'd like to show here, the take-home message here is that, there is a time course for muscle injury and repair. And I'll show you some slides from our laboratory in a couple of minutes that suggest it's actually the first 24 hours that may be the most critical. So think about these athletes that have these hamstring injuries that are traveling, they're on the road or whatnot, and we don't get to them until 2 or 3 days later. Is that potentially setting us up for failure down the road? So this is another schematic that I borrowed from an article that's quoted here in the Journal of Orthopedic Translational Research, which again shows us that it's really that first stage, and we would argue that it's the neutrophils and the mast cells that actually set the stage for muscle repair. Now, for a long time, Dr. Howard and others thought it was the macrophage, but we would actually argue that it's the neutrophil, and I'll try to convince you of that over the next few slides. So this is a slide that I borrowed from my days when I was at Duke getting my PhD under Dr. Bill Garrett. And what we showed back in the late 80s was this typical time course. And again, this is going to be an anesthetized animal. So we would create an injury to the rabbit tibialis anterior, and we would follow the time course for muscle regeneration. So again, this is under anesthesia, so arguably we can get maximum motor unit recruitment, right? It's not like a human where we could argue that pain would limit their ability to generate isometric torque. And what do we see? Well, and this has been repeated by others, Rick Lieber, John Faulkner, who used to be at the University of Michigan, and just retired at the age of 94 years old. John as well showed this back in 1991, that you have this initial force decrement, but the muscle actually does worse over the first 24 hours, and then you start to recover. So again, what does that tell us about the clinical situation? And hopefully we'll provide some answers here this morning. So nevertheless, and this is another slide, this is when I was at the University of Wisconsin. Some of you may know this person, Stacy Brixton. She's actually a physical therapist who got her PhD with me. She has qualified and competed twice at Kona. So you can argue, if anybody wants to come and do a PhD with me, you'll have lots of time to train, is what Stacy would tell you. Nevertheless, what she showed was, and I mentioned earlier, the neutrophils. So our feeling is that it's the neutrophils that are critical for successful muscle repair, if you will. And what you can see here is a time course for the neutrophils actually coming into that injured muscle, and that also is coupled to oxygen-derived free radical repair. And this was mentioned earlier this morning in one of the talks, that maybe oxygen-free radicals are important as well. So what Stacy decided to do is to say, well, how do I prevent those neutrophils from moving into the muscle, and how do I then prevent that respiratory burst from appearing? And what we were able to do, this was in collaboration with a colleague from Harvard University, who was actually a cardiologist by the name of Dan Simons, and at the time he was doing a phase 2 study in patients with who had sustained myocardial infarction. They would get this monoclonal antibody called M170. They'd block the neutrophils from entering the muscle undergoing ischemia, and they would actually show that the muscle, they wouldn't get as much muscle damage, if you will. And so what I'm showing here is on the top is a control-treated animal where you see a lot of torn fibers. But if you pre-treat with this antibody that blocks the neutrophil from entering the muscle, you can actually not sustain the same amount of damage. So it kind of fits with our hypothesis that it's the neutrophil that's really the key player here. And if we block the neutrophils from entering the muscle and undergoing that respiratory burst, maybe you can block that so-called secondary injury, which then correlates back to that decrement in force that we see in the first 24 hours. So here's some data from Stacy's PhD that she published in the Journal of Applied Physiology about 15 years ago now. And as you can see, if you pre-treat these animals before we create the injury, we can actually show a reduction in the number of torn muscle fibers. Okay, so let's move forward here and look more specifically at now tissue injury and repair. So again, we would argue that the neutrophils are critical, that if you block those neutrophils from entering the muscle early after that injury occurs, you block that respiratory burst, maybe that muscle is going to do better, if you will, not sustain as much damage. So let's now take a closer look at the connective tissue. And this was a topic, again, when I was at the University of Wisconsin working with Brian Heiderscheid, who many of you may know, and Daryl Phelan and Mark Sherry. We became very interested in this, because getting back to this idea about secondary injury, right? So we know, for example, with the hamstring, right? As Peter Bruckner would tell you, the only secret he ever said was, you know, Tom, he says, when they think they're ready to go back, give them another week, and you'll reduce the incidence of injury. And I think that's something we forget, right? And again, I hope we get to this morning, this whole idea about shared decision-making. The way I put it with our athletes now who sustain these muscle injuries, such as a hamstring strain, is I can't give them a number that says what their risk is, but what I can tell them is you can reduce that risk if you're out a few days longer. And I think that's something, you know, we get back to this idea about time-based versus criterion-based, but time does heal all wounds, as we say, right? Or as we used to say, Dr. Fowler used to say, hurry up and treat them because they're going to get better, and that way you get credit for it. So I mentioned earlier connective tissue, right? This is critical to muscle repair, obviously, because that's what carries the load. You know, we get these injuries. So we became very interested in this and actually looking at the amount of scar tissue that was formed, and we developed an approach where we could do a 3D analysis to calculate how much of the hamstring actually showed scar tissue as a function of the entire volume. And to make a long story short, it showed most of the hamstring injuries that we treated, at least when I was at the University of Wisconsin, we were only seeing 1 to 2% of the muscle was actually forming true scar tissue. So our next hypothesis, and the one we're testing now, is that it may be more central or neurologic. And so stay tuned, and I'd love to share that data with you over the next few years, because one of my beliefs is that when we get these hamstring injuries is that it's a central, whether it's an adaptation or a maladaptation. I don't think it's a structural problem with scar tissue. I think it's got more to do with the neurological aspects. Nevertheless, this is to show how a healthy muscle heals, and you can see here that typical inflammatory regenerative phase and then remodeling. But what we know, right, is that muscle can scar. And what does scar do? Well, we argue that it affects the ability or the risk for re-injury. Again, I'm not so sure that's the case. But if you look at some of these unfortunate individuals, for example, with the muscular dystrophies, or you look at aging skeletal muscle, we do in fact see more scar tissue there. Now, whether that's related to the deposition or the absence of dystrophin, or is it really just the fact that they're set up for fibrosis, we don't know. So I want to bring this full gear and talk a little bit about sort of the clinical side of this. Where does the rubber meet the road, if you will? It's great that we could have our laboratory funded. I had students get PhDs, and I'm very fortunate and blessed to have done that. But the reality is we got to take it back to the patient. So one of the topics we became interested in was nonsteroidal anti-inflammatories. So we went back and looked at the literature. This is just as I made the move to Ohio State back in 2005. And lo and behold, again, if you look in the basic science literature, there seems to be a dose-response effect of nonsteroidals on skeletal muscle repair. In other words, high doses of nonsteroidals can actually inhibit satellite cell activation and proliferation. Now again, I accept that that's in tissue culture, and you would say, well, how does that apply to humans? Well, here you go. Here's a study published in the Journal of Applied Physiology, right? This is a very reputable journal. Back in 2009, this was a Scandinavian study, and they essentially did the same thing looking at an eccentric exercise protocol and then actually set up an infusion system, if you will, to infuse anti-inflammatories into the exercised muscle. And the take-home message was similar, that high doses of anti-inflammatories could actually suppress muscle regeneration, i.e. looking at satellite cell activation. So here's the kicker. This is a study that many of you may be aware of. I think this is a great example of a study where when you first read the abstract, you read one thing, but when you actually read through the paper, the conclusions may be different. Nevertheless, this comes from a very respected colleague, Dr. John Bergfeld, who I'm sure many of you know. And Bergie had this idea that he said, Tom, he said, it's very simple. He said, he was looking after the Cleveland Browns at the time. He said, I go in, I don't need ultrasound, I can tell you where that injury is, and if I can get to them the day of the injury and inject corticosteroids, I can actually get them back quicker to sports. And I'm sure there's enough gray hair, absent hair in the audience to remember this study that came out, and it really did sort of rock the world, I think, of muscle injury and repair. So it's a retrospective review, as we know. Nevertheless, what I'm not here to do is to criticize Dr. Bergfeld, because I hold him in very high regard. I think, though, this was an important study that's been lost in the literature and is something we need to come back to. He admitted there were many limitations, there were no controls, et cetera, et cetera. But the bottom line is he made an important observation, right? And we do this in clinic every day. It doesn't necessarily have to be a level 1 study to contribute to the literature. So again, if you go back and look, John would argue that by putting corticosteroids into that area in the first 24 hours, that he could get the athletes back to safely back, if you will, with minimal risk for re-injury. And so that brings me full circle to our point about that first 24 hours, and maybe this will come up in the discussion period. But it's something we think is very important in terms of trying to treat muscle injuries. And here's the sort of take-home message from, and this is verbatim from John's paper, is that our impression is that IM corticosteroid injections hastens players' return to full play and lessens the game and practice time they may miss. So again, this was back in 2000 that Dr. Bergfeld and others said that, and I think that's been lost in the literature and something we need to come back to. So just to kind of summarize, again, the time course for muscle injury and repair seems to be pretty well established, at least in animal models. In humans, I think we base it on clinical observation, perhaps MRI. It does appear that inflammatory response is, key to successful repair, but again, the question is all of that necessary? Is there maybe too much inflammation? Should we selectively try to recruit those or knock down those neutrophils? Don't forget the satellite cell, right? There won't be a test afterwards, but just if you see me tonight, just say, yeah, I know satellite cell is the muscle stem cell and everything will be good. The immunology is probably important too, and then again, if fibrosis can interfere with normal muscle repair, but at least if you look at the data out of the University of Wisconsin, the amount of scar tissue that forms in even these most significant hamstring injuries is really quite minimal. So I appreciate your attention, and I'll turn it back to the moderator of this session so we can have a fun next few minutes here talking about orthobiologics and muscle repair.
Thanks, Dr.